Hi everybody, this is Kyra Mann, CEO of MitoActive. We are here live in Pasadena with Dr. Boles. We just finished our live patient education forum, and so Dr. Boles is going to spend some time taking the questions that you all submitted on Facebook Live. So we are here not only with MitoActive, but CVSA, and we are excited to be here together with both organizations to answer your questions with Dr. Boles.
Okay, so the first question we have, Dr. Boles, is what is the best way to get proper treatment in the ER? So many doctors and nurses have no idea what CVS is or how they claim it's CHS. I use cannabis to help with symptoms, but I have stopped for long periods of time to test to see if it could be cannabis or found no difference.
They are very good questions. There's actually kind of two questions here. The first one is about the emergency room, and the second one is about cannabis. In terms of the emergency room, it's a big problem. Most families know little about, most medical professionals know very little about CVS. It's not just CVS, but there's tens of thousands of rare disorders. Several percent of people, some up to 10-20% of the population suffers from a rare disorder. And there's tens of thousands of them, and it's just really impossible to educate every doctor in every emergency room and every urgent care about them. The best way to handle that is to have a physician that can fight for you, somebody that is a family physician, a pediatrician, an internist that cares about you, it is knowledgeable about your condition, and will talk to the person in the emergency room and say, this is my patient, this is what I want done, and this is why that you do it. That person doesn't have to be an expert on CVS. It's probably very unlikely that they will be. But as long as they're willing to work with an expert and they're curious and they're willing to learn and willing to talk and work with others, I think that's a really good situation. The second question is about cannabis. The use of cannabis in society has changed dramatically. Not that it's really increasing, but it's certainly coming out of the closet, and it's a mainstream part of medicine today. It's not everyone that agrees with that. There's several people in the medical areas that really disagree with cannabis use. I find that it can be very helpful in many of my patients, but like any drug, it has its uses and it has its abuses. And if you've been on cannabis and you went off of cannabis and it doesn't change it at all, that's not cannabis hyperemesis syndrome. That's CVS, and cannabis has been helping. Unfortunately, not everyone in every emergency room setting will believe that. Again, it really comes down to having a doctor that will talk for you and say, no, this is not cannabis hyperemesis syndrome, that I have been following this patient, they went off of cannabis for 3 months, nothing happened, their use is medical cannabis at a moderate amount, and I mean, that's really, it really comes down to is having a physician that you trust and that will work with you. That's not easy to find.
Thank you. So the next question was, what are your thoughts on a child with probable mitochondrial disease, EDS, migraines, cyclic vomiting, gluten sensitivity, and seizure disorder trying the ketogenic diet?
Okay, first of all is that take out the Myto for a second. Those are descriptive terms. I mean, cyclic vomiting syndrome describes vomiting in cycles. EDS describes someone in most cases who has hypermobile joints and maybe the skin as well. These are just descriptions. The vast majority of the diagnoses that we use are simply descriptions. Sometimes they're in English, sometimes they're in Latin, sometimes they're in Greek, but they're really just what the patient said and nothing more. So it really, you have to look at the underlying problem. In mitochondrial, you're talking about a presumed etiology. And I have patients going back for decades that have mitochondrial dysfunction, and they do have that, but many times mitochondrial disease is not the primary abnormality. When we do genetic testing, we find something like an ion channelopathy, sometimes something else like a neurotransmitter abnormality, sometimes it is mitochondrial disease. But all of these can end up with mitochondrial dysfunction. I went for this long thing because I don't know. Based upon that description, there's just no way of knowing. And it would require a full evaluation. One thing to be careful on is that certain types of mitochondrial disease, particularly fatty acid oxidation disorders, it can be very dangerous with a ketogenic diet. So what I would say to that person is only do it under medical supervision, and only if your doctor agrees.
Mm-hmm. Wonderful, thank you. Why does weather affect my CVS symptoms?
Well, there's dysautonomia in many of these. The autonomic nervous system or the automatic nervous system, dys just means bad. CVS is part of dysautonomia. There's many other dysautonomias out there, or dysautonomic related conditions. In mitochondrial disease or mitochondrial dysfunction, you get a lot of dysautonomia. The autonomic nervous system controls the amount of blood that goes to various parts of the body. It keeps the body at the right temperature. Weather is going to change the stimuli that goes to the skin, and it's going to change the autonomic nervous system. Weather can affect many different diseases. In particular, Myto and dysautonomias are affected by weather.
The question came in, how can a child with mitochondrial disease get sick easily and crash hard, but still have normal functioning immune system? Labs show that they aren't immunocompromised.
Okay, people talk about neurological problems all the time because the nerves are electrical, the brain is electrical, it requires a lot of energy, and if there's a problem with the mitochondria, which is the energy machinery, oftentimes it's the brain that's the first thing that's affected. But people forget about the fact that the immune system also requires a lot of energy, and it's also very complicated. So people with mitochondrial disease will often have bizarre and unusual neurological problems that come and go and are hard to diagnose. Same thing with the immune system. Problems come and go and are hard to diagnose. Sometimes they won't show up at any testing at all. Sometimes they will, and then it goes away on the next test, or it may even be the opposite on the next test. Things go up, things go down, sometimes they're in the middle. So the immune system is really complicated on that. Many of these patients have what some people call chronic variable immunodeficiency. And it just means they get sick a lot and no one can really figure it out. And it is very hard to figure out. I'd say on the average, patients with mitochondrial disease tend to get hit hard with viral illnesses like colds and flus. They may get it more often, they may get it more severe, they may be more prolonged, but they rarely get really serious infections. I mean, everything has exceptions, but it's rare that they get infections such as in their brain or in their spine or in their hip or someplace that you don't normally see infections. And they don't usually get opportunistic infections like you see with AIDS or leukemia. Things like Cryptococcus or Kaposi's or Pneumocystis or something like that. So they don't have a classic immunodeficiency like an AIDS situation, but they can get sick very often. It makes it difficult to diagnose.
Thank you.
Next one's pretty long, so I'm just going to kind of chop it down to the last little bit. About it's a 21-year-old college student that wants to know how she can contribute to research being done on CVS.
There's very little that's being done, unfortunately. Functional disorders such as CVS, even though they're the major cause of disability in this country, get very little funding. Whatever studies there are in CVS are going to be on the CVSA website, or you can contact the CVS.
Thank you.
Next question was, if a mother had MELAS and passes that to her son, but not her daughter not showing any percentage, is there any chance that the daughter's children could have MELAS?
Yes, because you don't know where the mitochondria have gone. It may be low in the saliva or in the blood or some other tissue that was looked at, but it may be high in the ovaries. In general, if it's much lower in the blood and in the saliva than in the relatives, probably the ovaries are going to be low as well, but you don't know that for sure. So it is possible, but less likely than, we'll just say that it's hard to really answer the question because I don't know what the percentages are, but the only way I really can answer is yes, it's possible.
Yes, we appreciate your answering without seeing these patients or
Okay,
or knowing the whole history of their
Yes,
story.
right. I mean,
Yes.
that has to be the caveat and everything here, is that my answers should be considered general,
Right,
and
yes.
not necessarily for a specific situation.
Right, thank you. Will genetic testing help determine mitochondrial dysfunction and/or CVS, and if so, what to do about it?
I just gave an entire lecture on that. I could speak for an hour on that. And So, can you give the information as to how to get to my lecture?
Yeah, absolutely. We'll be putting it up online later.
Okay. Yeah, I think I spoke for about an hour and 20 minutes.
On the topic.
Scratch the
Yeah,
surface of
just
it.
that
Okay.
topic, yes.
So we'll be posting that later this week on the
Okay.
page.
But
So.
for those that don't want to go for my hour and 20-minute lecture, the answer is yes. In many cases, yes, not guaranteed.
Okay. Genetic testing and eye testing for my daughter have both shown inconclusive. What test do you recommend to get an answer? Thank you so much in advance.
Oh, that's a very generalized question. And right now, it's the age of genetic testing. That's what the most powerful testing is. And it's a very generalized question, so this may not apply to that person at all, but genetic testing is really what things are at right now. And not to say that other testing is completely useless, but that's where most of the answers are. In my patients, it's very rare that I don't recommend genetic testing in all my patients.
Okay.
This next one we kind of already touched on. How can you get this information, findings, and protocol into the hands of ER doctors? I think she's addressing more of the adult side, which, as you know, we have the adult guidelines coming out for CVS.
Yes.
So that's kind of where I would refer that. The work's being done, the testing's being done.
Well, the protocol can be helpful because it can educate doctors on what you're doing.
Right.
But it's also important you really need a physician, in most cases, that's local to the area and preferably, but not absolutely necessarily, has privileges at that hospital. If it's a doctor that they recognize and has privileges at that hospital, they're likely to consider it more. If it's somebody who's far away that they've never heard of before, who doesn't even have a license in that state, they'll take it at advisory. So, I mean, that is difficult because not everyone has a local expert, but.
Okay, thank you.
So a question of, they said, I'm a 60-year-old with MELAS, one of 4 siblings with mitochondrial disease, muscle biopsies positive in all 4, and our mother who passed at 42 from MELAS. What is the life expectancy of someone with mitochondrial disease?
I'm going to answer that in the general and not about this family and not about MELAS. Mitochondrial disease used to be considered to be a death sentence, and you were going to get worse with time. It's progressive and it's going to be fatal. That could not be, I'm not saying that in every single case, that's not the case, but it's a minority of cases. I have a lot of patients. Deaths are very rare now. We have much better diagnostic and therapeutic modalities that we can do. I'd say that the vast majority of patients are non-progressive and the vast majority of patients are non-fatal. Now, I have several MELAS patients and they're all doing rather well. They're not progressing. It looks like they'll probably live a long time, and it becomes an issue because they'll outlive their parents. Again, that's not the case in all situations. The major exception are babies that are born with very severe mitochondrial disease and are in the NICU with severe lactic acidosis. Those are generally fatal. But beyond that, usually life expectancy is pretty good.
Great, thank you. Next one is how to get quick treatment at the hospital. Oftentimes the staff is not familiar with CVS and my daughter dehydrates quickly.
A protocol. Have your doctor have a protocol that it may be a detailed protocol that goes over a lot of different situations, but what could be bolded or underlined or in a different color or something is put an IV in and run this fluid at this rate immediately. So they can take a look at it and do that. IV fluid has very little risk and it's likely that they will do it. In terms of IV fluid, I always recommend D10 for my patients. That's not very popular with a lot of physicians. They're worried that the glucose will go too high and the sugar will go high. I want it to go high. The purpose is for the sugar to go sky high in the blood so that it turns the mitochondria off so that you can then get better. You want to kind of quell down the situation. You don't want the mitochondria going full speed making all these intermediates of metabolism. You want to just bring the glucose in there so that insulin will bring the mitochondria down. So if they can't get D10, and a lot of emergency rooms and urgent centers don't have that, have them run D5. And not with just water, with saline in it, half normal saline, full saline, the way they would normally do that. But it works much better with dextrose. And again, to get them to run fast, it's a protocol.
Okay, thank you.
Is it possible to get compartment syndrome due to mitochondrial disease?
Mitochondrial disease can do almost anything. I have not seen compartment syndrome yet.
Okay. Thank you.
Okay. As an adult with CVS, I was blown away when I learned of the mitochondrial connection. My GI doc actually did a blood test for my CoQ10 levels and found out mine were 3 times lower than they should be. My question, how did researchers discover that connection with respect to CVS?
I did. It's actually a funny story. There are GI people that, people come in with vomiting. And I'm a metabolic geneticist. And I see all these patients with mitochondrial disease that then start vomiting. And then I said, well, maybe we're seeing the same patients. And so that I got together with people like Beely and David Flesher and said, yeah, we're seeing all the same patients. We just call it by different names. So I'm not saying that every single patient with cyclic vomiting has mitochondrial dysfunction, but it's rare when one doesn't. And it's not the only cause of it. I mean, most common disorders, asthma, diabetes, you have many, many contributing factors. It's not just one pathway. In CVS, there's different things that are going on, but it seems like the vast majority of patients that I have seen have mitochondrial dysfunction, it's at least part of it.
Okay, thank you.
How can we find out if we have a mutation in the TRAP1 gene?
Genetic testing.
Okay.
But it won't be, the problem is that you can do genetic testing and they'll look at it and they will say it's normal, because the mutations that I have published that are relevant for cyclic vomiting are actually, most of them are not rare in the population. They're found in 1/2 of 1% or 1% of the population. So most labs won't say anything about it. They have to actually ask them to look at those mutations, or better, to go to an expert that will read the genetic testing looking for CVS and looking for the TRAP1.
Okay, thank you. Is it true that CVS can go into remission for long periods of time? If it can, how do we get our doctors to understand that we still have CVS and that this phenomenon does happen?
I mean, there have been patients that have gone into remission, but that's actually remarkably rare. You're very lucky. Many patients, with treatment, it will go into remission, but it only goes into remission as long as the treatment is. I've had multiple patients that have been in remission for years that for one reason or another decide to stop the medication. I'd say 80% of them relapse. Some of them didn't, and some of them are doing great. But most of them have relapse, and sometimes the relapse can be very difficult to treat. In other words, just putting them back on treatment is not good enough. You have to do other things. So we're talking biology, and biology, it's many, many things can happen. So if it happened in you, it's real, but you're lucky.
Thank you.
So next
one more thing.
Sure.
CVS can go to migraine, because CVS is a migraine-like condition. If it goes to migraine, it doesn't go in remission, it just changes the stripes.
Oh, perfect. The question from over here was, can you have Myto without ragged red fibers?
Almost nobody with Myto has ragged red fibers.
Okay.
If your Myto is muscle disease, and if you're an adult, having mitochondrial dysfunction in your muscle eventually tears them apart, and you will see ragged red fibers.
Mm-hmm.
If you are a child or a person of any age without severe muscle disease, you won't have it.
Okay. Thank you.
If left untreated, will CVS become fatal? I'm speaking of my brown urine full of ketones, going without fluids for up to 8 days straight. Then there's post-CVS migraine I get from my blood pressure being sky high. No triptan will touch those migraines.
I have had a couple patients with CVS that have died, but the CVS was in remission for many years. It was other more severe problems with mitochondrial disease which eventually killed the patient. But that's over like 25 years of dealing with it. I think there's been 2. And in both of those, CVS is a very small part of their disease. I have heard of other patients across the country that have died, and it's usually been opiate abuse, overdose, or suicide. It's not a fatal disease in general.
Okay, thank you.
I just want to, there was a question that came in on the live. Yes, this is being recorded and it will be posted, and you can watch it from the beginning when we post it. So yes, it's going to be posted on the pages that it's being recorded on. So I did just come in and I saw it, so I just wanted to address it. The next question is, my son has possible Myto. He was status epileptic and has spent 3 weeks in the ICU, failed tons of meds. His CK was 9,500. He's still on 4 meds, Seizure and Myto cocktail, and still has daily and nightly seizures. His one possible variant, his gene study was 44%. His sister is older. It's a long one, so I'll go a little slower. And she is 5 and was status epileptic at 15 months. Her results came in and she had same variant at 34%. Now we are super worried about her. Is it possible for both siblings to have the same Myto disease? My son just had a muscle biopsy, and we're now waiting the results.
Okay, first of all, that's a remarkably specific question.
I know.
Even if I went through the entire chart and examined the children, I might not be able to answer those questions because they're so specific.
So I guess the real question is, can 2 siblings have the same Myto disease?
Oh, definitely.
Yes.
And the percent that you gave is probably in blood or saliva. It may not be the same in brain.
Yeah.
I have seen cases before in which 2 siblings, one's more severe than the other, and it has a lesser percentage. We did not do a brain biopsy, and we're not going to do that. I presume that might give us the answer. But I mean, it's the percentage in blood and saliva does not always correlate to heart, brain, nerves, and other tissues that really matter on this.
Okay, thank you.
Will CoQ10 enzyme and L-carnitine, along with dietary protocol of fasting avoidance, decrease the occurrence of or completely resolve the CVS episodes?
In some people, it seems that's all that you need. There's a few caveats on there. Most CoQ on the market is worthless. It's not bioavailable, so you have to get one that has good bioavailability. I think I can say brand names on this. There's 2 companies which make really good CoQ. They're Tishcon and Kaneka, in my opinion, and they have many different brand names that they sell it under. The ones that I'm aware of are Trader Joe's, but it's only the gel capsules on that. It's also Solus, Cunol, and Epic for Health. Those are good brands. They have good bioavailability. Ubiquinol with an OL at the end is a form of CoQ which goes into the brain better than ubiquinone. It's a little bit more bioavailable, but a lot of this is controversial, and different people will say different things. I generally recommend ubiquinol, the OL, when possible. It's difficult to find a liquid preparation of ubiquinol. I think Solus is the only one that has it. There are gel capsules for the other companies. Carnitine and CoQ. Carnitine doesn't seem to matter as much, in my opinion, on the brand. Carnitine and CoQ, you need to get blood levels. I like the CoQ blood levels to be higher than 4.0. The normal range is up to about 1.2 in a lot of labs, so it's really sky high. So it'll come back at 2.5, and the lab will be all upset because it's sky high, and I'll say, not nearly high enough, we need to give more. With carnitine, I like the free carnitine, the FREE, to be higher than 40, at least higher than 35. It really depends on when you do blood levels, most of the time people's levels are really low. How much you have to give to get a blood level that's in the right range depends dramatically on the patient. In some patients, 200 twice a day of CoQ is good enough. In other patients, they need 1,200 twice a day. It really depends. It depends also on the brand, of course, so some are more bioavailable than others. Having said that, a lot of patients, particularly with mild CVS, CoQ, carnitine, and other things, is probably, will help a lot. And even if it's not enough, you can reduce the medications. I now have a new product, Spectrum Needs, that's marketed by NeuroNeeds. So just go NeuroNeeds, NeuroNeeds.com. Caveat I have to say is that I own part of the company, so if you order it, I might get a little bit from that, but I really, I put this together because my patients were taking up to 10 different things. In cyclic vomiting syndrome, I use this as well as in autism and in many other mitochondrial related conditions. And it has 33 active ingredients, including 20 different parts of the mitochondrial cocktail. It's not for everybody, and obviously speak to your doctor about any of this, CoQ, carnitine, Spectrum Needs, or anything. I know I'm spending a lot of time, but this is a really important question. The other thing is many patients do need drug treatment, particularly the more severe patients. I use the nutrition part first because that's good enough in some, and even if it's not, you can use lesser amounts of drugs. Amitriptyline is often the first line drug over 5, cyproheptadine under 5, but there are many other drugs out there. I typically treat medications based on genetic testing because I want to treat the underlying problem, not just a description.
Okay, because there was a question that was asking for your top 3 preventer drugs, top 3 prophylactic drugs, and top 3 during episode.
Okay, for cyclic vomiting syndrome, again, I use the mitochondrial cocktail in terms of spectrum needs and additional CoQ because there's not enough CoQ in there. I like to use the ubiquinol, and I've already spoken about the different types. I try that first, and then I use the drug depending on the genetic testing. If the genetic testing suggests a mitochondrial disease, amitriptyline is my first go-to, and Zofran is my second one. That's sertraline. If it shows a channelopathy, I treat the channelopathy in question. If it's a calcium channel A1A or A1S or sodium channel 4A gene, I use acetazolamide, which is Diamox. And if it's the RYR2 gene, I use propranolol, which is Inderal. And then there's many other causes out there, so I treat the underlying genetic abnormality instead of just the description, which is cyclic vomiting.
Okay, thank you. Have a lady that's asking, can lack of estrogen or other female hormones be what caused my CVS to start? I'm currently 50, however, my episodes begin at age 47.
Oh boy, I'm a pediatrician. I'm sorry, I don't know.
Okay, let's see. What is the best way to explain to your employer that you randomly get vomiting episodes that can last for an hour to days, especially when episodes are frequent?
That's difficult. If you have a letter for an emergency room, that might, go over to some degree. Information from the CVSA website, maybe print out some and highlight some of that. That's a good question. I'm not quite sure. I deal with, again, as a pediatrician, I'm mostly dealing with schools. And often I will write a letter to the school explaining what the condition is, and in the school letter it will say that they will get episodes and what the signs are, and that they will be missing school to go to doctor's appointments and when they're ill.
So just going to add to it a little bit, because FMLA would be for adults if they were taking care of kids. So would you write anything different in the FMLA than you would for Family Leave Medical Act?
Oh, I'm a pediatrician, sorry. I'm not the right person to answer that. I would think that the letter could be very similar in that the difference might be is that you don't expect the employer to be watching the employee like the teachers would watch the children for early signs of disease.
Okay.
But the other parts of the letter that would say that they have that condition, that they're likely to require occasional doctor's offices and illnesses and everything.
Okay. I have another one that says, what role does the vagus nerve play in CVS symptoms? What strategies could help support or distract the vagus nerve?
The vagus nerve is a major part of the autonomic nervous system. The vagus nerve provides a lot of the innervation to the gut. There are other nerves that come out of the spine that also provide the rest of the innervation to the gut in terms of the autonomic nervous system. So together, they are extremely important in CVS. I tend to look at this as a geneticist from a molecular level and find out where the variants are that may or may not be related to disease, and then treat those appropriately. Other people tend to look at this more of a systems approach, particularly the GI doctors, and they look at which drugs will increase or decrease certain parts of the autonomic nervous system. So I know that there's a research being done on it, and there's some people that are working with various stimulation techniques and everything. It's just outside of my main area of expertise.
Perfect, thank you. Is there a genetic test that can confirm CVS yet?
Nothing can confirm anything. There are genetic, if you have CVS or not, it's a descriptive diagnosis. You meet the description, you have it. What the genetic test does is it finds the risk factors which predispose towards CVS in you so that you know how to treat it. It doesn't confirm or deny the disease. No, anyone say that genetic test is normal, therefore you don't have something. We don't understand all of genetics. No one can do that.
Okay, thank you. What triggers the beginning of this syndrome? Stress, food?
It's genetic. I mean, it's a genetic predisposition. Triggers are different in everybody. Usually the triggers have to do with increasing energy demands because they're stresses, lack of sleep, viral illnesses, alcohol, over-exercise, psychological stress, surgery, anesthesia, I mean, you name it. Those are all triggers which can trigger it off, but the underlying issue is genetic.
Okay, thank you. What tests are recommended to confirm CVS? How helpful is Nortriptyline in younger patients?
Okay, CVS is a description. There is no test to find it. In my experience, but this is unpublished, in my experience, early in an episode, ketones will be high in the blood and particularly in the urine. And yes, ketones are high in starvation, but if you ate 6, 8, 12 hours ago, you should not be ketotic unless you were starving yourself with some sort of very draconian diet. So if you have ketosis early in an episode of vomiting, that's sort of a test which I find very comforting, that not only is it clear that there's CVS, but there's a there's a mitochondrial component to that CVS. It can help doctors by saying that there is actually a laboratory test that confirms what they can already see. But other than that, it's not extremely helpful. The second part of the question was Nortriptyline?
Yes, for younger patients.
Yeah, amitriptyline breaks down to nortriptyline in the body, and both amitriptyline and nortriptyline are actually active metabolites. In my own experience, I have found that nortriptyline is not as helpful as amitriptyline in CVS. Some other doctors have said the same thing. Some have said they disagree. No one's studied it.
Okay.
I don't give nortriptyline for that reason. I give amitriptyline, but.
Okay, and this one is kind of focused toward the adult side, so they're asking.
Okay, I'll do my best.
They're asking what your secret weapons for treatment are.
Molecular genetic testing and nutrition. Proper nutrition and genetic testing.
Okay. How likely is it that children will grow out of this condition permanently?
A good proportion, I don't know if it's half or so, of the small children that get it will go to migraine headache at somewhere around puberty, within a couple of years of puberty starting. The migraine headaches are usually much well tolerated by the family and the patient than the CVS. It's treated the same way. It's the same disease, it's just changed the way it shows. Sometimes the disease will go away on its own. It does that sometimes, like any disease, but I find more often it goes into migraine.
Okay. What do you recommend for a child who has CVS and also gets very sick when riding in a car?
A lot of them have motion sickness. There are over-the-counter medications that can help on that, but they're not all that effective. I don't have a really good answer to that. Okay. It's common though.
What causes the extreme stomach pain?
The extreme what?
Stomach pain.
It can be different. Abdominal migraine and CVS are, in my opinion, exactly the same condition. You call it abdominal migraine when the pain is the worst problem. You call it CVS when it's nausea or vomiting is the worst problem. But it generally is the same condition. And many times, if the pain is stereotypical, meaning it's their pain, it's in the same place, it's the same quality, it's just kind of the same thing, that's probably part of the CVS or abdominal migraine. The other thing is the CVS is that the bowels really kind of shut down completely and nothing moves, and so it's like having a stomach with a bunch of stuff in it that's not moving. That can be painful as well.
Which brings us to the next question, which probably relates to that. My daughter vomits bile only. If they take her gallbladder out, would that make a difference?
I doubt it. Many of my patients, particularly the older patients, somebody took the gallbladder out, and then somebody later took the appendix out. Neither of them really makes any difference. There have been a couple of exceptions of gallbladders that have been removed, and the gallbladders were quite obviously inflamed, and then they got better, but I would say the vast majority of them did not get any better.
Okay.
I don't know in that one case, okay? In your case, it may be what needs to be done. I cannot say in any particular case. These are all general information.
Yep, not individual. Why do I salivate so dang much when I'm not actually puking?
dysautonomia. Salivating is on the autonomic or the automatic nervous system.
Okay. When I'm having an episode, I am very mucusy. Is that a link?
Probably dysautonomia again.
Okay, thank you. What is in the future for treatment of CVS?
I know that this is kind of a thing that some doctors don't want me to talk about, but my patients don't have CVS anymore. I've gotten rid of CVS in all of my patients. So it's really the comorbidities that I'm working on now. Some of them required a few different drugs, and some of them required molecular DNA testing to find exactly what the problem is and then to put them on something. So it's not always the first thing works in everybody. But all my patients I've seen for over a year, none of them have vomiting anymore. They may, if they have a severe stressor, they may break through and have an episode, or they won't have another for 2 years. But they don't have vomiting episodes anymore. I'm really working on the comorbidities. It's the chronic fatigue is the main thing that I'm working on now, because that, when you get rid of the migraine, you get rid of the pain, all the other body pains, and you get rid of the cyclic vomiting, usually it's the chronic fatigue that's the worst problem. And I'm working on better and better mitochondrial directed treatments to try to deal with that. So I would say that better medications and nutrition in terms of mitochondria to try to relieve those.
Okay. We'll do one more. Will I need to take amitriptyline for the rest of my life?
Very good question. I always tell my patients, we will have that discussion if you want in 3 years. I don't even want to hear it until then. You've been 3 years, episode 3, then we can talk about the pros and cons. Some of the people decide after they hear what I have to say about most of the patients' relapse, and it can be pretty severe, to just stay on it because they're not having any side effects. Amitriptyline causes troubles early on. I would say half the patients, when they start amitriptyline, they don't feel well. They feel tired, they just don't feel right, they don't like it. Half the patients don't seem to have any trouble at all. But after they get used to it, they don't have any side effects whatsoever, and it's okay. And a lot of people are on amitriptyline for decades. In fact, in most of the world, amitriptyline is used for depression, not so much in this country anymore, because it's hard to use, but in the rest of the world, it's a great antidepressant. It seems to have good long-term safety profile, and it's very cheap. So it's used throughout the world. People don't seem to have issues on it. Some of them will want to go off of it eventually, and the way that I do that is to say, okay, we're going to reduce it very, very slowly, like over a year or two. And some of them do well on that. Some of them, a lot of them, when you get down a little bit, then they start having symptoms when they go back up, but nothing hurt. The major problem is when they want to get pregnant. If it's a girl and she's now a young woman, she gets married, she wants to have a baby, that's a problem because amitriptyline is category C. It could cause trouble in the infant, and then we have to talk about the pros and cons. Often that says, okay, let's try to wean you and see if you tolerate it. If you do, that's great. If you don't, well, these are the risk factors. They're not really draconian, but it's not risk-free.
Okay, perfect. Thank you so much for your time today.
Yes, we want to thank you for your time and answering these questions in a very tough scenario of not knowing
Right.
these people that are asking these questions, and you're answering them in a very general, not seeing anybody's.
For all the attorneys out there that are salivating at my answers, I gave no direct medical advice. Talk to your doctor.
Talk
Yes.
to your doctor.
Yes. Thank you so much for your time. We will post his conference and everything that he went over today in Pasadena, California. We'll post the entire conference later on this week on MitoActive on CVS's page. And we thank you for your time today. Thank you, Dr. Boles.
You're welcome.
Thank you.